Hello, everyone, and welcome to today's AAHAM webinar, COVID-19 Future Impact 2021 Financial Exposure. At this point, I'd like to introduce our speakers for today, Lyman Sornberger, who's the CEO of LHS Consultant, and Steve Mullin, who's the Executive Vice President of Business Development and Marketing at Bluemark. At this point, I'd like to pass the floor over to Lyman to begin.
And thank you again, Stephen, for this opportunity to have this discussion with AAHAM. I think this discussion is going to be a little bit invigorating and a challenge for all of us, but to the providers, payers, and peers and colleagues on this engagement, I truly want to say we thank you for the opportunity with this education session. So our learning objectives today are pretty simple. Maybe some rules of engagement, a little different than we've been accustomed to in the past, that I won't have to navigate you to where the restrooms are or anything else. But what we want to talk to today is review the impacts of COVID-19 and what the challenges are with the clinicals, financials, and operations. Identify and discuss the specific within those areas and what we are challenged with today, and then maybe have a significant discussion around the technology solutions to help mitigate the impact of what is going to happen. So let me spend a few minutes just to say something around what our challenges are today. So we know that COVID has created a major challenge for us. The election of our new presidency will determine what might change. The Supreme Court, the ACA, will also challenge all of us in the revenue cycle management. Telemedicine has created a huge change for us, and positive and a challenge. And then unemployment and those underinsured or uninsured are going to be a challenge for everybody in this industry. So I think that it's a great discussion for all of us to have as healthcare industry leaders to have that conversation. It's going to impact clinical, financial, and operational challenges. And I'm going to talk to that more in detail. You're also hearing that transparency and pricing is going to be a challenge for 2021, meaning that you are going to have to, as a provider, disclose what your costs are related. And then you have mergers of healthcare industries, huge, that are going to create closures of certain hospitals, as well as an opportunity for everyone to be more collaborative on the provider side. And then I'm going to share with you the value proposition and the reimbursement challenges you have and the opportunities you have. And again, thank you to Bluemark as an example of what will be your reimbursement challenges. And then your risk. The risk will talk around what's your exposure, and you can talk about, artificial intelligence, business intelligence, rapid payment automation, or managing around machines, okay? But at the end of the day, we're going to talk a little bit around how all of those challenges from the basis to where we have been historically and we're going to in the future. And I call it the new normal, okay? And many others do as well. So pre-COVID-19, hospital focused on three challenges: reimbursement, cost, and consumerism and branding. So those were probably our biggest challenges in the provider, vendor, and I don't call them vendors, I call them partners, challenges. But post-COVID-19, we have to focus on these three challenges: reimbursement resources versus elective. So let me speak to that. So right now in the industry, on COVID-19, and whether you call it whatever challenge, is that you're paid around $2,500. On an elective service, you're paid on average about $6,000. Obviously, that's a provider concern. So the payer response to COVID-19 has been, all right, I need to just pay it. Why? Why would I pay that when I don't have to? And on the payer response, it's pretty much automated response, which is they could not opt out, which means that behind CMS, who has said they're going to pay for COVID-19 with those symptoms and that DRG, that is the challenge for the payer. Then you move in to telemedicine, and I'll talk to a little bit more about that and why it's an opportunity for the industry. And then telecommunicating. How are you doing with digitals? And then what is the new normal? So if you look at the background, we already know that coronavirus hits in 2020. The coding has been identified. Here's a little challenge for my group on this call. The flu is going to start, and the same symptoms are going to follow what has been diagnosed as COVID-19, okay? So fevers, headaches, everything else is also going to be a challenge for all of us as to how you diagnose this. Unemployment climbs from 3 to 16%. How are you addressing that as a provider or a partner vendor in the industry to complement the fact that it's going to be a challenge? Elective surgeries are placed on the back burner. Now, you hear today that they're going to be pushed up to the front, but 32% of the national industry is saying they are increasing COVID problems without a flu. So you're going to recognize a difference in the payment between $6,500 historically on average to $3,000. And what will providers decide to do in the future with that decrease in reimbursement? Telemedicine increases. That's kind of a positive thing. Let me stress this. People don't want to go into a hospital anymore. They're scared to go in. They're scared if they even have a fever to go in. And from that perspective, be respectful of behavioral health is going to be the next telemedicine challenge. But the advantage to it is that you will have an opportunity now as a provider to recognize what you could do with providers and payers to change that. And then industry workers are deployed to home. So remember that. So is that going to change the industry for healthcare? Yes, without question. Whether it be pre-access or whether it be clinical or whether it be the back office. Clinically, we've done a better job of saying we could do this as well, remote, onshore and offshore. But at the same time, I don't think that that's going to change in any way. And then the government. So again, I mentioned what was going to happen with, the election. You can talk about whether it's going to be the Senate or whether it's going to be the new federal government guidelines around ACA. It's going to be a challenge. So my first poll question, Michael, is with the transition to staff deployed to work from home, do you anticipate your personnel in the future to continue to work from home?
And audience members, you should see that question live on your screen. So we'll give you just a moment here to select your answer, yes or no, and we do have your results coming in.
Thank you, Michael.
Again, audience members, with the transition to staff deployed to work from home, do you anticipate your personnel in the future to continue to work from home? And we'll give, again, just a couple seconds here to finish up answering. All right, and we're seeing results starting to slow down here. So it looks like we have 81% say yes. I just moved, but 82% yes and 18% no.
Wow, that doesn't actually surprise me, honestly, Michael, because I think that bricks and mortar are changing now. IT staff can work, and they were forced to work from home. And from now, they've already invested in that change. So I don't think that's probably surprising to me. So let's move to the clinical impact. So we already know there's new coding for COVID-19. And then providers are holding COVID claims. So let me sprinkle into that what I'm seeing in the industry around providers holding claims. There's two things that I have found. I have found two major health systems that have said, all right, we held the claims and then we started to code them. And then others said we just released them. And based on the provider's understanding. And what do providers understand? They understand financially that under COVID, they were going to be paid. That's not going to be true for a long term, okay? So let's be respectful of that. And many of them coded them on their own, rightfully so, educated to say, this patient had a fever, this patient had a headache, and they coded them with that respect. And now they're being audited. And now they're being denied. So understand that the new world doesn't mean that it's a blanket opportunity. And it's going to change in the next quarter. So audits will happen, denials are going to happen. And be respectful of that. The next is provider billing for do not resuscitate. Never in my career of 33 years in healthcare did I think that someone could code for do not resuscitate under COVID or any other condition. But that is the real world that we're living in today. The new telemedicine instructions give us clear HIPAA privilege to say, for now, under telemedicine, which is probably the way of the future, that PHI is less of a risk. But if you watch what's going on with major payers, by the end of the year, telemedicine is going to change. Only from a PHI perspective. Remember what I said about behavioral health? And remember that it will be a requirement. And remember, denials and audits will come back into our world of revenue cycle management. And that's what I mean by relaxation of quality requirements, which means for right now, under what we know of COVID-19 is everyone's willing to pay. But if you look at certain payers today, they are going to restrict those requirements because they, as a payer, can't afford to do that and just say, I'm going to pay. And then there's a decreased demand of elective surgical coding, which has to change. Providers cannot live on a combined rate of Medicare and Medicaid healthcare, paying them at roughly 30 cents on a dollar. They've relied on the patient to complement that. Whether that's right or wrong, that's not for me to decide. But they need to live on about 50 cents to 55 cents on a dollar. That's a fact, without question. And then remember that patients can't afford their out-of-pocket expense with high deductibles. So it's a challenge for all of us. So audits have requested that we pause during this problem with COVID, and rightfully so. So here's a poll question. What percentage of your revenue cycle middle operations, HIM team, coding, CDI, and audit staff will return to their original work environment?
And audience members, you should see that poll live on your screen as well, so we'll give you some time here to answer that question. Again, what percentage of your RCM, HIM teams, coding, CDI, and audit staff will return to their original work environment? And your options here are less than 50%, about 50%, or more than 50%. And again, we'll give you just a moment here to get your answer in. All right, and I see results starting to slow down. So it looks like we have 55% say less than 50%, 25% saying approximately 50%, and 20% there saying more than 50%.
Michael, that's an interesting response, because I believe that many people are doing onshore or offshore, and a lot of clinical coding and CDI, etc., can be done remotely. So to bring them back in the house is interesting to hear that it's 50-50 and 50. But I understand why they would like them to be there, because they need more physician interaction. But I'm thinking with like companies like Epic, Cerner, and Meditech, they can have that interaction from an electronic perspective. So let's talk about the financials. So I went to med school and veterinary school, and I might sound like I'm confused, but let me share with you my perspective. Providers are seeing a significant decrease in cash flow, without question. And now there's an increase of cost of 5.4%. So on the hospital side, that was typically 3 to 7%. On the physician side, it could range whether you're, whether you're running emergency room or surgery, but it was roughly around 7%. But everyone is experiencing about a 5.4% increase. There's an increased need for patient financing. And what I mean by that is you can see a number of regulations that are going out there in the industry. And what I want to share with you is a couple examples. So, America First Health Care Plan, the White House has directed that the Secretary of Human Health Services provide updated information on Medicare government beneficiaries of hospital billing quality. The information must be provided within 180 days of the order, and that was issued on September 24th. So basically, what they're saying is you have to tell the government of your billing quality. No definition. But honestly, you are going to be required to say that we have demonstrated that we have done billing quality. Let me add to that. The updates to that website says how often the hospital pursues legal action against patients. So we remember 501R, including garnishing wages to place a lien on the patient's home or to withdraw money from the patient's income tax. That legislation says you have 180 days as a provider to demonstrate what you're doing. So as a collection agency, your hands are tied as a creditor. You cannot credit report pretty much on anyone. 501R already pushed that button, and this legislation is telling you from HHS that you cannot do that. And you have 120 days as a provider to demonstrate that you are not doing that. That's a huge struggle for providers. And 30 years on the provider side, which I believe only that people should pay they can afford to pay, is going to be a challenge for all of us. And let's move to improper ERISA. So already in the industry, we're seeing payers saying you accepted COVID payments or you accepted this DRG, and you might think you're underpaid, but you are going to accept this payment. And that's from the provider and the payer and their acknowledgement of whether they're willing to accept that. So you are going to see an increase in denials, and this is not going away in the next quarter. This is not going away in the next year. It's not going away probably for a couple of years. Keeps us all employed. You're going to see an increase in payers saying you accepted this and just bite the bullet. You're going to see an increase in audits because of COVID, even with their comorbidity. And understand that. But be respectful of it, because you don't have to just bite the bullet. Your accounts receivables are going to age. And there's going to be a demand for additional staffing. And I stress this from the standpoint of, from a provider world, no one is more respectful after having 2,000 employees that I committed to train and committed to educate and lost them, and never respectful as much as I could have been or should have been of how much I invested in them. And then consumerism. Consumerism in the past world meant we got to do everything the patient wants. Consumerism now means you also have to be respectful of what you need to do for the industry. And then the access to COVID versus elective, without a question, operationally, is a huge challenge from access to the back office. So remember what I said to you. You're not going to make you're going to make less than half on COVID. Add to that the flu and how you're going to diagnose that. And you are going to make half of what you historically made. And I don't want to be a Debbie Downer, but remember that. And remember that the coding defined as other medical conditions. So remember this perspective. Today we report everyone COVID with any fever, headache, or anything because we want to get paid as a provider. Okay? And payers are agreeing to do that today. That's not going to happen in the future. That's not going to happen in 2021. I don't care whoever we elect or whoever we put in to our senators, it's still going to be a challenge. Billing telemedicine is going to change. Behavioral health is going to be a huge issue. And they're going to release the requirements for PHI. AR management, denials, and audits are going to increase. Whether we want to believe it or not, for right now, whatever behavior we have done, and bad debt collections, early out, and third party are going to be a challenge for everyone. So here's a poll question. Have you changed your self-pay collection strategy? Michael?
Yep, and audience members, you should see that live on your screen. So again, we'll give you a moment here to select your answer. Again, have you changed your self-pay collection strategy? And your options here to choose from are yes or no. And we'll give you, again, I see your results coming in here, so we'll give you just another few moments to get those last answers in. All right, and this one's pretty close right now. It looks like we have 56% say no and 44% say yes.
So, and it might have been a better question to look at that and say early out versus post-collection, third party. So I think early out, everyone's scared with COVID. How do you be, consumer friendly and not pursue the patient? And then yet on third party, you're like intimidated that you're fearful that you're going to risk the brand of whoever you're associated. So here's some questions of leadership. How are we measuring the impact of COVID clinically and financially? I've talked to you about this a little bit in depth, but remember this because it's not going to change in the fourth quarter. It's probably not even going to change in 2021. Do you have a strategy, short and long term, regarding the implications of this? There's no vaccine that's going to really happen immediately. And even if it does happen in the fourth quarter of this year, you're not going to see a financial impact to that as a provider or a partner vendor. Do you have a backup plan? And I stressed it to project what are your strategies around this. You could just say, we're just going to go status quo, or we think we have a strategy, but we don't have a partner or a relationship if it fails. And then how are we in the future going to measure consumerism? Are we going to measure it from the patient's world that we have measured it in the last few ears or push that button? Or are we going to measure it of our brand as a provider and a vendor to be collaborative? So probably my last poll question, what would you define today as your system, revenue cycle, PFS strategy to respond to the COVID-19? Are you going to pause and hold, or are you going to make proactive changes? Michael?
And audience members, again, you should see this poll live on your screen. So again, we'll give you just a moment here to select your answer. What would you define today as your system's RCM PFS strategy to respond to the COVID-19 pandemic? Again, is it the pause and hold or proactive changes? And it looks like we have a lot of your answers in already. We'll give it just another second here to see if these slow down just a little bit. All right, and it looks like we have 83% say proactive changes and 17% say pause and hold.
Well, Michael, I'm pleased to hear that, because the reason why we're doing webinars and we cannot do vendor, trade shows or anything to be more interactive, the answer to that should be you need to be strategically proactive from your front, middle, and back office of your revenue cycle management. And that's not just coming from me as a consultant. It's coming from me as, here's what I experienced. I'll give two examples. Telemedicine, two large health systems being audited and denied lately in the last 2 months. Why? Providers heard, I'm going to be paid under COVID, and I am under telemedicine, and I heard that I will get paid. And they billed all highest level. And now they're being audited. The second is a provider that said, I heard that as long as I coded it under COVID, I will be paid, and no matter what my documentation. And now they're being audited. So don't be disrespectful of just as today's world sounds like we're going to get paid, as being disrespectful of the fact that you still need to understand the rules. And I try to train providers, and I financially and clinically, but at the same time, they hear different words, and we all know that. And then vendors need to be appreciated as partners as well, and understand that strategically, you need to think about that from an education perspective. I'm not here to promote me. I'm here to promote what we need to do as an industry. So here are the new solutions, quickly before I hand this off to Steve, and he's probably ready to beat me. Artificial intelligence, business intelligence, digital consumerism, telecommunity, partnerships, and automation. They're all things that I try to stress. So, we started with BI, business intelligence. That's all around data collection. Smart move. I get it. All right. Artificial intelligence is, what does the industry need? All right. From a provider, from a vendor, partner, and from, from a consumer. My mother, your father, etc. What do they need? They also want digital. You'd be surprised that 80% of consumers now want digital. Even though we're all in a millennium, like myself, over 60, that we didn't think we wanted digital, but we do. I hate to text. I'm not thrilled about email, but I deal with it. So remember that. And then telecommunicating, which means your phone. How many? My mother knows how to use her phone better than anybody else's mother, trust me. Partnerships, I mentioned again, they're vendors and they are partners. And you need a strategy around that. And then you need to work around automation. It's the way of the future. It's not going to work. I don't care whether you're on Epic, Cerner, Meditech, you name them. I don't care. All scripts, you need automation as the way of the future. So with that, Steve's probably going to beat me up, but here are the national statistics that you are welcome to share with your peers. And my next poll question to you, Michael, is the operational impact to patient responsibility. Are you noticing an increase in self-pay responsibility, uninsured or underinsured?
Yeah, and audience members, you should see that on your screen, so we'll give you a moment here to answer. Yes, again, are you noticing an increase in self-pay responsibilities for uninsured and or underinsured since COVID-19? All right, and it looks like we have, the results are coming in, they just moved a little bit more, so we'll give everybody just another second here to answer. All right, and it looks like we have 63% who say yes and 37% who say no.
That doesn't surprise me at all, Michael. I mean, high deductible plans move now into the unemployed, and it's only going to get worse, team. And so, again, not to be a Debbie Downer, but I want to just stress that you need a strategy to prepare yourself in the future. And with that, I'm going to hand it off to Steve.
Great, thank you, Lyman, for your comments and for the introduction. You always bring a great deal of insight to the world of healthcare revenue cycle management. I also want to just quickly thank the folks at AAHAM for hosting us this afternoon, and also everyone who's attending. Looks like we've got some great attendance on the program today. I know it's not always easy to take this chunk of time out of your day, but we appreciate you joining us today and listening to the presentation, and hopefully the information that we're bringing to you, has some value. So just before I jump into my slides and talk about some of the technology solutions that are available today that might help to meet a few of these challenges, let me just give you just a very quick introduction of Bluemark. We're a specialized software developer. We provide revenue cycle solutions for healthcare professionals. Our solutions help clients in really three main areas. First is how do they achieve workflow efficiencies? How do they reduce operational costs? And where appropriate, how do they maximize revenue? So we offer solutions really in two spaces, two areas. The first is in self-pay management, and then the second is audit management and response. So I'm going to take the slides back over here and just kind of, Lyman just quickly passed over this slide, but I did just want to touch on a few of these specific points. So, we originally put this presentation together. Good news. We're back to 7.9%. That approximately, Steve,
breaking up a little bit here. Steve, why don't I have you go ahead and refresh your control panel there, your browser, and then reconnect for me real quick.
All right, I will do that.
Everybody, just give us just a minute here while we have Steve reconnect here. I'm just going to have him refresh, and he'll be reconnecting his audio here in just a minute. So, all right, Steve, when you're ready, just go ahead and unmute yourself, and you should be good to go.
Is that any better, Michael?
That is.
Okay. So let me just go back to the slide we were on. So a little bit of better news. The unemployment rate continues to go down. The latest report had us at about 7.9% nationally, which means there's still about 13.5 million people currently out of work. In different regions of the country are impacted in different ways. Certainly in the Northeast, Florida, California, are certainly higher than that. And as you can imagine, that has resulted in a lot of people who have lost their health insurance. So the statistic comes from Kaiser Family Foundation. There are over 10 million people have lost their employer-sponsored health insurance, which is not surprising given the unemployment rate. And when you add in families, you're looking at that number approaching 27 million who have lost insurance. So, we've got a lot of folks that do not currently have health insurance. The other impact that we're looking at, and Lyman touched on, is certainly the loss of revenue. So, I don't need to necessarily quote the statistics from the American Hospital Association, but certainly there are hundreds of billions of dollars of revenue that have been lost. And the one that really touches specifically on the PFS side, and one that we'll look at when we talk about technology, is this idea of contactless patient engagement. So we did have some polling questions, and we had some things in the discussion around remote workers and folks not returning to traditional working models. So looking at strategies and tools that help support a contactless patient engagement model will certainly be a help to you and something for you to consider as we move forward. So let's start with self-pay management. So when you think about best practice solutions and technology in self-pay management, it's really about how do you control the self-pay management process. And really the goal is to ensure that the right patients get enrolled in the right programs every time. So the envelope of services can vary. Certainly when we're talking about the hospital, the healthcare environment, we're looking at things like Medicaid and hospital-based financial insurance programs. You can extend that and also think about things like health insurance through the exchanges. And then there's also, typically a wide variety of other social service programs that might be available, whether they are, government-funded charity care programs or local county-based programs, but there typically are potentially a larger envelope of assistance programs available to folks. So, what do you want from a technology platform, right? You want to be able to manage all of these accounts and all activity in one solution. What you're going to find is a lot of the information required for all of these different programs is fairly consistent. There's about 80 to 85% of information in data, demographic data, data about the individual that is shared across any of these applications for these programs. So having the ability to manage all account activity in one place can drive a lot of value. Certainly one of the goals, or potentially the largest goal, is to identify all potential revenue reimbursement opportunities first. So you'd want to think about it in terms of, kind of like a pyramid. The first thing you want to look at is, are there available reimbursement opportunities where you're going to get paid for the services you provide? And then from there, are there other programs that are potentially available, whether it's going down a financial assistance track or other potential programs that would have benefit, for the patient population and the community at large. Well, the other thing you want to use or looking at technology to do is you want to lower the overall cost of program enrollment. So whether you're using, some manual processes today, doing, manual interviews, tracking things on spreadsheets, or even utilizing third-party vendors, to help with the eligibility and enrollment process, you can certainly leverage technology to lower that cost. The next thing, one of the great things about technology is it can be highly configurable. So, there are a lot of unique needs that I'm sure most of you have as part of your organization. And, using a technology tool that can match those needs can really drive a lot of value. What you don't want to do, or what you want to protect yourself against, is having to learn a whole new process as you're implementing a whole new technology solution. So looking at tools that are configurable to your specific needs can bring a high degree of value for you. How can you increase productivity? So certainly one of the main values of technology is automation. So how can we move things through a process from identifying potential eligibility all the way through enrollment in the fewest amount of steps with the least amount of touch. So using technology and automation to move accounts through can drive a lot of value, save a lot of time and cost. It also adds a layer of certainly control and accountability through the process. And then the last thing we have on here, which is of a lot of importance, is not just compliance, both internal and external, but also reporting requirements. So now using your platform to give you a higher degree of visibility into accounts, into your process, into the results of the eligibility enrollment process, and where accounts potentially get enrolled can drive a great deal of value. So when we think about a feature set, we've sort of narrowed it down to kind of 4 different specific areas that can drive some tremendous value for you. The first one, and we're going to actually touch on these in a little more detail as we go through the slides as well, but just at the highest level, the first is around outreach and engagement. So, how can you leverage self-service tools, patient portals, electronic communication with your patient population? Lyman mentioned in his comments about, kind of the shifting demographics of the patient population. All right, it's not the baby boomers, the Gen Xers. We're now Gen Z, millennials, and the like that are really becoming a larger part of your patient population. And that group really wants to be communicated in an electronic way. They're not engaging face to face, over the phone, through the mail. It's on demand. It's through the web and through portals. So how do you leverage those tools to help support some of the outreach activity that you have, to get in touch with those patients, and then how do you utilize those tools from an ongoing engagement perspective? Again, we'll kind of come back to that contactless engagement point again in a moment. The next thing we have is the rapid assessment. So you want to be able to position yourself to collect as little data as you can, or the minimum amount of data to get you to an assessment of what potential program somebody might be eligible for. So there are a lot of screening tools out there that do, it's a quick 2 to 3 minute interview where you're defining a household, you're identifying the financial conditions, and you're able to provide a result of potential eligibility that will then direct you down an enrollment workflow. So that can save a lot of time if somebody's potentially eligible for a program. It's worth the effort to move down that enrollment pathway and seek to get them ultimately enrolled in that program. The third key feature is electronic application submission. So again, we'll touch on that again in a subsequent slide. But how do you use some of the submission portals that are available today? Whether they be consumer-based portals, whether they be certified application counselor portals or assister portals. How do you leverage electronic application submission to simplify the process and also reduce the cycle time of potentially getting somebody enrolled in a program? And then the last thing is really sort of the umbrella that covers this entire process. It is, the reporting tools, the management tools, the account processing tools, that really allow the organization, whether it be supervisors, managers, directors, to really understand what's happening within their patient financial services department, but also with regard to self-pay patient activity. And then the final piece of that, again, is the reporting and being able to report on the final disposition of your self-pay accounts and hopefully converting them to different assistance-based programs. So let's drill into these in a little more detail. So again, the first one is the outreach and engagement, and that's really done through patient portals. As we mentioned, patients are increasingly more digital with their interactions. Right? They want things, kind of on demand, on their time, through web-based applications, whether it's on their smartphone, which is typically the way somebody will be engaging with these applications, or if it's on, on a computer, on a website. So, what are some of the values of the patient portals? Certainly, it supports contactless engagement strategies. Whether it's part of the outreach process, whether it's part of the ongoing communication process. You can push things. You can both push things through a portal to a target audience, and you can also collect things back through the portal that helps support the process. So when we think about the front end of that and the outreach, you can certainly integrate this with texting, email, QR codes, web links. There's a whole host of ways in which you can drive individuals to your portal. Once they're on your portal, you have control over what you want them to do. They can do everything from screening, so whether it's a self-screen for Medicaid or financial assistance, whether it's based on results of that screen to schedule a follow-up appointment or a follow-up call with a financial counselor. Once they're engaged in the process, you can have them supply additional application information and or collect survey patient satisfaction information. And you can also collect and allow somebody to submit required documentation. There is a lot of new technology available today, which either allows you to access things like your camera roll and take a picture of a document, submit that, or if you're on a computer, certainly just uploading a document and submitting that back into the financial counselor. You can all do that through a portal. The other thing you can do is you could potentially support electronic signature. Whether if it's on a computer, you're typically doing that with a mouse, or if you're on your smartphone, you typically can do that with a finger signature. So where it's applicable, and typically this might be more on the financial assistance side rather than the government program side, but you can collect an electronic signature, through a patient portal. And then the final piece is really supporting some of that communication back and forth between the financial counselor and the self-pay patient. So, if they need to get some information, they can send out, a text, direct them to the portal. They can, kind of see what the status of their account is, what's needed for them to move through the process, and or, they can either text back or submit information back through the portal. So, portals are definitely gaining a lot of momentum. I think they've certainly been around in the clinical space now for probably the last, 7 or 8 years, and have gained momentum. But now, as we think about them specifically as a tool within patient financial services, within the revenue cycle, and how it can, help with some of the specific challenges we're dealing with today, they're certainly gaining some momentum. So, assistant program assessment. So that was, really the quick screening process. So this is an example of a screening tool, and you're really looking for two key pieces of information or two groups of information. The first one is trying to identify the household. So who is within that household? What are some of the relationships between the members of the household, and maybe some other categorical questions that you want to ask as well. The bottom half is the financial picture. Typically in a quick screening process, you're just looking for income for the members of the household. You also could collect things like expenses and or other assets, depending upon how you want to utilize that information, potentially for a financial assistance program or for other program eligibility. So it really is nice because for a couple of reasons. One is you can distribute a tool like this across your enterprise. So you're not limited to just the financial counseling department and a financial counselor to be able to administer this screen. Anybody from patient access to somebody in your outlying clinics could easily walk through this process with an individual and get them potentially screened for a program. The second thing is it allows you to document the process. So all of this information would be saved in your self-pay platform. So not only the questions that you asked, the answers that were given, and the results that you came up with are all saved. So if you ever needed, or if you ever had the occasion to be audited internally, externally, on how you were approaching the screening of self-pay patients, you have all that information documented in your technology platform. The third piece I wanted to touch on, again, was the application submission process. And as I mentioned, what we have found is, well, a couple of things. First thing is, there's no, and for the most part, there is not the ability to directly export data into, a state-based application submission portal. So this is not a data-to-data exchange of information. So what we have done and what others have done is we create something that's called kind of a front door interface, where that is, it leverages your browser. So it'll open up two windows in the browser, and then you'll be able to share information from one window to the next. So you have the patient demographic information in your self-pay platform. You've gone through your screening process. It looks like they might be eligible for a Medicaid program. Now you want to submit that application and continue along the process. When you open up the state-based exchange, I think this picture here is for the state of Virginia as an example, but you'd open up that portal, and then you could share data between the two windows. So it really facilitates, it eliminates a lot of the duplicate data entry, and it really facilitates the application submission process. There are two different types of portals. One is what I would refer to as the consumer-based portal. That would be the one that is any citizen of a state would go to that state-based portal and be able to apply for different programs. The other model is some states have a facilitated enroller or certified application counselor, or a specific model for those who are actually helping somebody apply for a program. So the process isn't different. It's just somehow how you access the tool might be a little different depending upon the type of portal that the state is supporting. But once you open up those browsers, you can easily share information. There's a couple of different approaches to sharing information here. You see in the picture that, the browser will highlight where it shared information. So think about it like when you go to a website that you've been on before and your browser assist is turned on, when it goes to, enter your first name or your last name or your address, your system is smart enough to know what that information is, and it will pre-populate it. It's the same type of process. So we will highlight the fields a certain color so you know where we have shared information, and then it will port that information over. So that's one way to share information. The other way is through opening up these little windows, these little applets that will have kind of a pick list of information that you can actively choose which would go into any of those given fields. So the nice thing about the second approach is it's more portable across multiple applications. So depending upon what programs you're looking at, if you're just strictly looking at Medicaid, then you're really only looking at one site. But if there are some other programs that have different portals, when you have kind of this pick list approach, it gives you a little more flexibility in your ability to leverage the sharing of information across those browsers. If you're using that first model, you're kind of locked into the way the application appears, and if the state should change something, or change a field or an order, or some of the information that they're collecting, really the whole system kind of breaks down and needs to be, kind of reconfigured. There's a couple of different approaches in terms of application submission. And again, the hope is, I speak for the technology folks, and hopefully that there will be a point where, we'll actually be able to share raw data. We won't have to do this kind of front-end interface, and we'll be able to submit data directly to a state-based system to simplify that application process. So I'm going to shift gears now and talk a little bit about the world of audit management. So as I mentioned, kind of Bluemark touches both sides of this process, kind of the front end on the PFS side, and then the audit management and response side. So let's touch on, so what are some of the challenges, as it relates to audits? So I'm sure, as many of you had known and Lyman mentioned, CMS paused audit activity, at the onset of the COVID-19 pandemic and the declaration of the national health emergency. CMS paused, their Medicare RAC audit activity. What we also found is many commercial insurance companies followed suit. So we sort of had this industry-wide pause of audit activity. That changed in the end of July. So in CMS's July FAQ release that they sent out, they did announce that. Hello? Am I still there? Michael, I assume you still have me? Well, hopefully he'll jump in, but I'm going to continue. So the pause was lifted the end of July, and audit activity has started. Some of the early COVID-19 related audits include, as we could all imagine they would, COVID related coding levels. Those are now being scrutinized and looked at a little more closely, and also telemedicine. We recently hosted a roundtable with a bunch of our clients to kind of get a feel for, what they were experiencing. And it seems like it's somewhat regional. There were certain parts of the country, New York, Ohio, Illinois, that were seeing, activity picking up. And there were some areas, Southwest and West, even Southeast, where it had yet to pick up. It continues to change, but, certainly audits are back and that activity is picking up. So what are some of the benefits of an audit management solution? So similarly with, kind of a self-pay management solution, how about an audit management solution? And really it's focused on a few things, but it's protecting reimbursement revenue. So whether that's specifically on the Medicare side, Medicaid, commercial insurance, anything that might be subject to review and audit, having an audit management solution in place will better position you to defend against that and protect those reimbursement dollars. The next thing is, how do you ensure you're in compliance with all of the rules around the audit process? So there are things like, very strict deadlines in terms of when you need to respond. If you do choose to move through an appeal process, what are the steps in that appeal? What are the rules around, how you appeal, when you appeal, and how you move through that process. The next benefit is, it can be time consuming. So how do you do things similar on the self-pay side to automate steps in that process, freeing your staff up to do more value-added processes. And the last one is understanding and measuring the financial impact of audit activity. Whether that is looking at things currently under audit, or if that's looking at things that as a result of audits and audit activity. Measuring financial impact is really a benefit of having an audit platform in place. We have talked to some clients that they have dedicated resources that their only job is to generate reports. So to track, monitor, and generate reports on audit activity. So here's I believe this is our last polling question. So Michael, if you wanna do the polling question.
Yeah, so audience members, you should now see that poll live on your screen. And it says, do you see an increase of denials and audits? So financial impacts, do you see any increase of denials and audits? Yes, by more than 10% from your historical volume. No, by less than 10%. Or nothing has changed. And we'll give you just a moment here to select your answer. Again, do you see an increase of denials and audits? Yes, more than 10%. No, less than 10%, or nothing has changed. And your results are starting to slow down here. So looks like we have, as I say that, it moves. As I say that, here we go. 58% say yes, more than 10%, 17% no, less than 10%, and 26% say nothing has changed.
Thank you, Michael, and thank you for everyone responding. Yeah, I mean that is consistent with what we've heard, from our clients as part of the roundtable, that your volume is increasing. So if it hasn't quite hit you yet, I think it will, certainly in the next couple of months. So let's look at some of the key features of a technology solution in the audit management side, and what are some of the things that you should be looking for in a solution. The first one is interface automation. So we've got the next slide kind of breaks that down. But it's essentially, how do you position your audit management platform? The term we use is the backbone, as the backbone of your audit management solution, where information is being shared and fed into the system to support the audit management process. And then information comes out of that system, that are either results or activities that are happening within the audit process that need to be shared with other systems. So, critical to have an automated system in place. The next thing that we'll also spend a little more time on is your release of information process. So, there have been a lot of changes with CMS's ESMD program in terms of the release of phase 2, and we'll talk about that in a moment. But having an integrated ROI process within your audit management platform, certainly facilitates the entire audit management response process. What are the tools that helps you manage your cases? So manage the audits as they go through the process, whether they be status models, whether they be workflows, whether they be work queues, activity notifications. If we're looking at folks in a remote world, then being able to have a solution that not only keeps you on track with deadlines and next steps in the process, but also notifies you. A lot of these solutions will trigger an email. So when something happens into somebody's work queue, an email will get fired off and say, "Hey, Steve, you've got a new task. Please go to your audit solution and review that task and move it to the next step." Last thing, or the next thing is, hopefully the tool is customizable for your commercial payers. So, certainly the rules around the Medicare audits are government-based, statute-based, so they're consistent across, the entire country. Medicaid is a little different because there might be some regional or statewide, differences for Medicaid audits. But commercial insurance audits are really going to be dictated by your contracts. So hopefully the solution has the ability to do some degree of customization to support the commercial audit activity. And then the last thing, we have mentioned, the importance of reporting as part of the audit management process. So 2 more quick slides that are graphics, but help to reinforce some of the key functionality that I just mentioned. So here is, kind of a diagram of, what a backbone platform looks like. So you've got your audit solution in the middle. You're bringing information in from either your HIS system, your 835, 837s, your claims remittance information into your audit platform. You're potentially bringing in the electronic documentation requests from the ESMD system on the Medicare claims. You're submitting information back. You can export billing indicators and other status updates back to your HIS system from your audit platform. And then if you're using other third parties to support this process, whether it be an ROI vendor that helps with the documentation submission process, or an appeals management vendor or appeals management system, you'll want to share information with them and also bring back information and statuses back into your platform. Automation can have some fairly dramatic results. Kind of a fully automated platform can reduce your data entry by as much as 90%. So we look at, okay, what data is required to move through an audit process in a fully integrated platform. We can reduce that to only 10%. So there can be a lot of gains with a fully integrated system. Last slide I have is really talking about the audit response process and release of information. As I mentioned, there've been some advancements with CMS with their ESMD program. Just before the pause, the COVID pandemic hit, they did release phase 2 of the ESMD program, and that is the process for providers receiving documentation requests electronically from the contractors. We have been able to submit documents for the last several years, but now with the EMDR process online, we kind of have this full cycle electronic process where the recovery contractors are able to send documentation requests electronically. The healthcare providers can then respond to those documentation requests and submit medical records through the ESMD process back to the contractors. So it really has simplified the audit response process, at least as it relates to the recovery contractor world. So with that, I believe we are going to open it up to questions.
Great. And audience members, as a reminder for today, if you would like to ask a question, you can use the Q&A tab on your screen, type in your question. Don't forget to hit the submit button. First question that we had here says, we are challenged with whether to post and hold claims due to COVID-19. What is the best practice?
This is Lyman, and I've seen both practices. Post and hold is a challenge, meaning that if you have any coding intervention. So I've seen many that have post and hold and then release them and now are under audit and denial. I recommend that you still have a clinical review and a release from your physician practice, because determining how they have been trained, they assumed or heard that they could just release it at a level 5 and be paid.
Great, thank you. And our next question here says, I utilize a third-party vendor for my Medicaid eligibility and enrollment. How can I take advantage of the latest self-pay management technology?
Lyman, you want me to take a first run at that?
Please, Steve.
Great. So, there's really kind of two different questions within that, at least how I would look at it. The first is the platform and what are the advantages that the platform will give you. And those are, as we discussed in the presentation. The second piece is, what resources do I leverage to work accounts through that process? And those resources can be either, kind of direct, hospital resources, either, if you've got dedicated financial counselors, or if you're potentially leveraging customer service folks, or other folks within your organization that in part, take part in the financial counseling process, or if you're leveraging the resources of a third-party vendor. So, they can all work and operate in the same platform, so you still get the advantages of the technology, but you do have some choices to make in terms of the resources that you leverage. From specifically a Bluemark perspective, I would say that 80% of our clients work in some kind of hybrid in-source, outsource environment, where they're managing some of the accounts with their own staff, and they're leveraging a third-party vendor for a subset or a segment of their accounts. The other thing I want to add into that as well is, typically you won't leverage a third-party vendor for your financial assistance program. Having all the information in one system, even if you do have a vendor focused on the Medicaid side, you can leverage a lot of the capabilities within the tool to manage the financial assistance side. Hopefully that helps. It's not really an in-source, outsource world anymore. It really is a blend of, a bunch of different approaches, all being held together and managed on one platform. Michael, I think you might be
on mute there. Yep, sorry about that. Our next question here says, what do you expect to be our greatest exposure in 2021 with revenue cycle management PFSs?
This is Lyman. I think it's going to be that the new world is going to change from we just paid for everything right now, and now we have a risk, and you're going to have denials and audits.
Great, thank you. Our next question here says, how secure is data that it is captured through the patient portals?
This is Steve. It depends on the portal, but typically there are a couple of different things that vendors employ to secure data. The first is kind of on the front end authentication. So you want to make sure that you've got the right person on the other end of that electronic communication. So if you're leveraging text, if you're leveraging email, typically you'll go through a multi-factor authentication process where you leverage, you have the phone number if you're texting, but how does that match, certainly a name, a date of birth, potentially last four of the social, but you might not have the social security number. So it's really kind of working with the vendor and defining, here's the information I have, how do I use that to validate and authenticate the individual on the other side. In terms of the sharing of information, you just want to make sure that all of the data is encrypted. So, just having a conversation with your vendor about, data and security and communications, both how information is communicated back and forth, but also where they're storing that data. Making sure that it is always encrypted and protected. So those are really the two different ways that you make sure that you protect information and data, not just going over the portals, but with any web-based tool, you would have some of those same concerns.
Yeah, Steve is spot on commentary, Michael, in the effect that providers are very sensitive right now about PHI and security. So I'm very confident that Bluemark is spot on with making sure that, and it should be cloud-based. I'll offer that conversation with my colleagues.
And I think we have time here for another question, maybe two. If you do have any other final questions, audience members, please make sure that you get them into the Q&A tab. Our next one here says, how easy would it be for my staff to adopt this new automation technology?
You want me to take it?
You want to take it, Steve, or me?
Well, go ahead. Well, why don't you start, and then I'll share any additional thoughts.
Yeah, I'm going to throw myself out under the bus. I had 2,200 employees, and this is a huge challenge for management. And I think, honestly, that it's an opportunity. I know you don't feel like that today, but in my opinion, it's you either do automation, like Steve and I are working on, to convince that it's the right thing to do, and be innovative and be digital. I agree with that. I also think there's an operational issue that we all have to deal with, and that is that we've deployed people to home, and good or bad or indifferent, and they are living with everything we all are living with. But I think that the right thing to do is to work towards innovation, automation, and be more effective in what we have done historically, which means that it's a new world. And revenue cycle is not going to go back to the old world. So I don't know if that answers the question, but I know that I feel it and deal with it every day.
Yeah, I would just add to that it's change, and change can be difficult sometimes. So my advice would be work with your vendor during if you do decide to employ a technology platform, really spend the time working with your vendor and defining the workflows for the accounts, so you really know and can understand where the automation is taking place. So what needs to happen through direct intervention from a financial counselor and or a patient, and what things are happening behind the scenes to keep the account moving. So having visibility into that, and then allowing that to translate into kind of the training and the go live and the post go live and the ongoing support that is often needed, is important. It's from the technology side, it's easy, right? Because things are automated, so it makes people's job easier, and ultimately it does. But there are some challenges to getting from the way I'm used to doing it to a new way. Even if I know and can see that new way is better, there still might be some challenges to get there.
Can I comment on that, Mike?
Yeah, go ahead, Lyman.
So let me stress that to my colleagues, I don't call colleagues vendors anymore. I know I worked on the provider side for 33 years, and I probably, was rude to them, and I wish I could take that back. But I call them now as partners and colleagues.
Great. Thank you, Lyman. So audience members, that is all the time that we have for today. So I'd like to thank Lyman and Steve for their excellent presentation today. And audience members, at this point, I'll call your attention to a survey that you should see have popped up on your screen. If you could please take a moment to fill out this brief survey, AAHAM does appreciate your feedback. This does conclude today's session. At this time, you may simply hang up or close out of your browser window. Thank you and have a great rest of your day.
Thank you, Mark.